So this particular webinar that we have devised with the help of infectious disease specialist, pulmonary intensivist, nephrologist, cardiologist, it's focused on those patients who are hospitalized and need acute care management. And this is a group of physicians to share their experiences and discuss the management dilemmas or any questions that they have while taking care of these patients to save lives. Today's speaker is my friend, Dr. Avais Masud, who is board certified in critical care medicine and nephrology. He is the program director of critical care nephrology fellowship at Jersey Shore University Medical Center in New Jersey. He's assistant professor of medicine in Seton Hall University School of Medicine in New Jersey. And he is actively dealing with many COVID-19 patients in the hospital and has wealth of experience. Welcome, Avais. Please share in next 10 to 15 minutes anything that you would like to share about your experience and about the disease.
Thank you, Shahid, and thank you, everybody. Let me add something that what exactly I have been doing for the last few weeks. Actually, yesterday we had this conference. It was very enjoyable. The reason being that it was very, like a discussion type rather than somebody giving lecture. Like it was very interactive. I hope we will have the same kind of discussion today. So anybody can ask me a question anytime. Actually, I'm a nephrologist and intensivist. So actually, my rotation is sometimes I'm doing nephrology, sometimes I'm doing critical care. For the last 2-3 weeks, actually, I'm doing mainly critical care, not only in my own university hospital, but also helping another hospital, which is in close to New York, in the epicenter of this COVID virus infection. So basically, I would just say a few things. After that, we'll start the question answer. I think that will lead to a good discussion. I will share my experience. Basically, we're not reached to peak yet. I mean, every day I go to hospital and the number of patients are more than the previous days. All the hospital in New Jersey has been changed totally. Like my own hospital, they have actually 3 additional ICU units. Pretty much more than half of the patients in the hospital are COVID positive or has to be like PGY, patient under investigation. And we're dealing all sort of complications from that. We are trying to try different medication. And we all know that no medication has proved to be a treatment, but some investigational, some have some experience. So we're trying different medication like hydroxychloroquine and some patient azithromycin and some other medication. Also, we have large number of ventilation, but looks like we are getting short of ventilators also. So that is a problem we are facing. So actually my advice or suggestion to folks in Pakistan is that so do your part. I'm sure you're already doing to educate more people over there how to prevent this. Because once, God forbid, this disease comes like America over there, it'll be too late. And we in America also a bit late, more than a bit, and we are seeing the consequences of that. So don't be, some people have different ideas for Pakistan that because we are malaria, probably that's why we are protective. That's not the case. Iran also has a lot of malaria. And some say that because of BCG vaccination, because of that, we will be protected. That's not the case. In China, they do the BCG. In Iran, they do the BCG. So please share your knowledge and education with other people that don't be in any illusion that it cannot come to Pakistan. So with that, I will just open up, just please ask questions that I think will lead to a nice discussion, I hope.
Very good. So, Dr. Avais, do you want to just go straight away to question and answers, or do you want to
I
review
mean,
any
I will
cases
be.
or lessons learned from any recent cases, something that was unusual?
I mean, yes, there are many things. I mean, I'm a nephrologist also, so we saw that a lot number of, if not majority, at least, particularly patient ICU. I'm dealing mostly in patient ICU. I got some patient in medical ward also. A big number, at least 25 or 30%, they end up in acute renal failure also. So that complicated things, and those patients had a lot of mortality. The other thing that we doing the treatment wise, we're doing the same thing what most of the people are doing. Everybody who's in hospital gets a hydroxychloroquine. We do use azithromycin also. We keep an eye on QT interval, but its risk is very low in the patient who has otherwise low cardiac history. So risk is very low. So I think we should not be too much scared of this arrhythmias. Uh, I'm sure Rizwan agree with me. Uh, he's a cardiologist, and I think he's also have joined. Uh, the other thing that we still don't know how uh, what makes some people do so good, some people do so bad. It doesn't matter they're young or old. We have seen patients who are very young, but they like within 24 hours or 48 hours, they were sort of okay to like almost died. And some patients they recovered. I know they talk about different strains of the this virus, but no study has shown that one strain is worse than other. So this is a thing which still a mystery why some people do good, some patients don't do good. So while I'm sure some participants are thinking about the question, so let me just go over that quickly. What the treatment we use commonly. So patients who are admitted, not even not only ICU patient, but other patient, pretty much everybody gets hydroxychloroquine, and many of them get azithromycin also. On top of that, we give vitamin C. Used to give about 2 weeks ago very high dose of vitamin C, 6,000 milligram IV every 12 hours. But now we cut down because the availability is less. We give still 1,000 milligram twice a day. Zinc, every patient gets about 220 milligram zinc. Zinc has shown that also delays the replication of the virus intracellularly. Actually, hydroxychloroquine actually helps zinc the transfer across the cell membrane. So that's why hydroxychloroquine actually helps zinc. Zinc has actually a more very significant role, theoretically at least, in slowing down the replication of virus intracellularly. Uh, so, and in addition to that, when patient is admitted, we do cover with the broad spectrum antibiotics in the beginning, just to make sure patient doesn't have any superadded infection, like ceftriaxone and azithromycin. Or if patient looks septic, then we go more broad spectrum antibiotics.
Thank you. Dr. Rizwan Khalid, please go ahead.
Ji, Assalamu alaikum, everybody. Thank you, Dr. Shahid, Rafiq, and Dr. Danish Bhatti for doing second webinar for APPNA MERIT. My name is Dr. Rizwan Khalid. I'm the president-elect of APPNA and a colleague of all our worthy panelist members over here. And I'm an associate professor of cardiology. I specialize in interventional cardiology and cardiac EP. I'm the director of cardiac EP here. So again, thank you everybody for joining. And I know that a bunch of our colleagues from Canada have also joined us from Calgary, Dr. Zahid, my good friend, Dr. Zahid Rafiq and Bhabi Fiza. So, you know, Avais, I think you were going to ask a question to me. I heard it half, but I did not get it. what you were asking. That's why I raised my hand. Do you want to repeat that question and I can answer?
No, one another question. I said that we use azithromycin and hydroxychloroquine. We have to keep an eye on QT prolongation, but otherwise, in a patient who has no history of heart disease, risk is pretty low. And I said, I hope you would agree with that, that the risk is kind of low on those patients who has no history of heart disease as well.
Exactly. And Wes, tomorrow I was going to give a talk, and I was going to very pertinent things about the cardiac involvement within COVID-19. And I was going to talk about the issue of QT prolongation and the incidence of torsade when both of the medications are given. I will just mention briefly for the audience over here about what the recommendations are and what I recommend doing. So basically, in a patient that does not have significant cardiac comorbidities, the risk of torsade is very low. And exactly as Dr. Avais Masud mentioned, so I 100% agree with that. However, you divide these patients at inpatients and outpatients. Some of your inpatients, who are critically ill, may have electrolyte abnormalities. So I would suggest that you do these patients for, at least for the first 24 hours. I'm not sure exactly what dose Avais you're using, but I thought it was like maybe 400 milligram BID for the first day. Do you use higher dose than that, or is that the dose
No,
you
you're
use?
right. 400 milligram twice a day, first day, and then 200 milligram twice a day for next 4 days.
For the next, so maybe for the first day or two, we do telemetry, and you can do EKGs and make sure that there is no significant increase in the QTC. If your baseline QTC is already prolonged, anywhere between 450 to 470, I'll be a little bit careful. And if there is an increase from day 1 to day 2 of at least 30 to 40%, you can keep that in ballpark figure in mind. Then you may have to decrease the dose. The other thing that you may have to look at is if your absolute value goes over 500, you have to be a little bit careful. If a patient has a bundle branch block, then you give a little bit more margin. If you look at the guidelines, they may increase a little bit more. Their guidelines suggest even from 470 to 500 milliseconds that you can still give it. And Avais, I will just add one thing that maybe the audience will be interested to know is that we used to use chloroquine for malaria in Pakistan, and the dose actually is much higher. You give almost 1 gram, which is 600 of base of chloroquine. Both chloroquine and hydroxychloroquine are sodium channel blockers, and also they affect the inward rectified current of potassium. So both of them are like your class 1 antiarrhythmics. So they do cause torsade. And we use chloroquine on patients as an outpatient for so many years in Pakistan, and nobody did QT monitoring or EKGs. So I guess just because now we are more aware of it, we tend to kind of do it more often. But I guess keeping the potassium over 4, magnesium over 2, if there's baseline QTC is very prolonged, we avoid it. You can do telemetry for 2 days and EKGs at least the first 2 days. That will be my recommendation. I'll discuss a little bit more tomorrow as well. Thank you very much again.
Thank you, Rizwan bhai. So I'm going to go ahead towards the question, but Shahid bhai reminded me again to ask you guys, as you get the mic to ask your question, please also introduce yourself, your name, your specialty, and what institution are you working at, and if you have any experience with treating any COVID patients. We'll appreciate that. Also, I would like to request for everyone to please type your name, specialty, and your institution in the chat box for people to refer back to in the chat box to look at. And then I have already 4 or 5 questions in queue, and I will take them in order that I received them. So Avais bhai, I think the most prudent question is the first question that we got in our WhatsApp group was about the concerns with the ACE inhibitors in patients with COVID. So most of the people are thinking there's a role of ACE inhibitor, and yesterday Sajid was saying that there may actually be a concerns with ACE inhibitor in COVID patient. What's your take on these things?
Okay, my favorite question, because I'm a nephrologist and I deal a lot with the ACE inhibitor, and I'm sure Rizwan also will be interested because he also deals a lot with the ACE inhibitor and ARBs. So basically, let me tell you about the receptors. So there's a ACE receptors and there are ACE2 receptors. So they're not the same. ACE2 receptors basically are like a counter effect, like to check the effect of ACE. And theoretically, when you have ACE receptor blocker inhibitors, so you can upgrade the ACE2 receptors. And ACE2 receptors are the one receptor with this S protein of the COVID virus attached to the cell for it to enter the cell. So theoretically, it looks like when you have upgrade of ACE2 receptors, that is bad and that increases the cell entry of the virus. But if you go in more details, actually there was a very good article in New England Journal of Medicine just a few days ago, and that gave me a lot of information that after that ACE2 receptor actually downgrade when the virus enters, and some studies show that that actually is protective. So ACE2 receptor actually is diminished expression actually is bad, and actually increased expression actually could be protective for that patient. So both are, nothing is proven, neither that protective effect or bad effect. So right now, the recommendation is that if a patient is taking ACE inhibitor because of congestive heart failure or because of blood pressure or because of nephrotic, because of proteinuria or diabetes, he or she should be continuing to take that, should not stop that. There's another question is whether a patient who is critically ill in ICU, should we stop that? My colleagues also tend to stop that, but after this we discussed that the other day, after this new article in New England Journal of Medicine, very good article actually. Now we tend to continue with that also. Some of the patients, not uncommonly in ICU, they have myocarditis. They actually have decreased their ejection fraction, and I think in that circumstances, ACE inhibitor are needed. So bottom line is that no, there is no definitely a proven any bad effect, so patients should be continue to take that.
Thank you, Dr. Avais. So next in line, I have Dr. Fizia Harikar. Dr. Fizia Harikar, please introduce yourself and then go ahead and ask your question.
Again, I'm Fizia Harikar. I'm an intern in ID specialist at Indus Hospital. And so I just had a question that do you think that COVID-19 has an independent effect on the kidneys? I mean, we have seen patients, or in fact, just one patient who had no other risk factors, and he just developed AKI, which was significantly worsening with, as far as the peak could assess, no other nephrotoxic drugs or comorbidities associated with it. So would it be that it is independent, because we've read about pericarditis, myocarditis, but independently affecting the kidney?
Yes, actually, from all these studies mostly came from China. What we learn as a nephrologist that they not only affects the other organs like lung and liver function abnormality, actually affect the kidney in a different way. Some mild effect is that you will see the creatinine is same, but you will see some hematuria and proteinuria. And I have seen some nephrologists in the beginning, like a few weeks ago, we started to, when we saw that patient has a slight increased creatinine and proteinuria and hematuria, they started to order other tests to find out some other cause. But now we know that this is due to COVID virus infection. It can happen, it actually happens in the proteinuria and hematuria even before the creatinine rises. The other thing I have noticed that particularly patient in ICU, they are very catabolic, and because of inflammation or whatever the mechanism is, the renal function, like any patient with multi-organ failure or ARDS also, they go to renal failure quickly, and once they start renal failure, creatinine starts rising, their potassium goes rapidly, very quickly. I had a patient just 2 weeks ago, and his urine output dropped, and his creatinine started rising a little bit, like 1.5 to 2. I said, okay, we'll do something tomorrow. There's no need for even thinking about dialysis. But by the night, his potassium was already like almost 7. So we have to dialyze the patient at the middle of the night. And that my experience is with multiple patients like this. They also, when you have patients who has rising urine creatinine and seems like patient going through acute kidney injury, uh, obviously you would like to keep the patient dry, but have to be keep limit. Don't have to be overhydrated patient. But I have very low threshold to put patient on bicarb drip. That actually takes care of their metabolic acidosis and also hyperkalemia. So that is my take on this. If you go on to details like what modality of dialysis we use, that's a different topic.
Thank you, Dr. Avais. So I have next Dr. Fawad Chaudhry in queue. Fawad, please introduce yourself and ask your question or comment.
Okay. Can you hear me?
Yes.
So, Fawad Chaudhry, I'm interventional pulmonologist and intensivist, currently assistant professor at University of Oklahoma. So, Avais, thank you for your sharing your experience. Just had a couple questions about the same subject. How's your experience in your center regarding mortality on the ventilator patients? Because of course there is different Italian and Chinese, and the initial papers have still above 50%. And is there any difference that you have seen there using remdesivir versus toci?
Actually, I have tried to get remdesivir. I was not able to. But a colleague of mine, he in a different hospital where I also work, he was able to get that, and the patient got it. Unfortunately, that's the. I was also saw those patients were like coverage, but not my primary patient. Those patients, probably you saw that in the New York Times and on the news, that the family of 7, they all had this, and most of them, they have no past medical history. They all died. So they all received this medication. Some of the patients also received, but those patients probably were too far already. I did not see any significant improvement with that. Mortality is really very high, very depressing. Once patient is on intubation, we use ECMO, everything we are doing here, but still the mortality is very high, particularly patient elderly patient. I know now, there's only a few patients who actually came out of it and were discharged out of ICU. All remember that most of them were young patients in their 30s or 40s. So yeah, you're right. Mortality is very high, unfortunately, in ICU patient or intubated patients. But I think I cannot say just because I experienced only a few patients. But I have seen that effect of that interleukin 6 inhibitors that seems to be has some positive effect in my very short and small experience.
Thank you. And thank you, Fawad, for being here. I see there are some questions about event management that will be coming up, and we'll appreciate your expertise on that too. And I saw some new people join, so I want to remind everyone, please write your name, specialty, and institute in the chat box. You can ask question in the chat box. You can also use the Q&A feature of the Zoom to ask question or raise your hand, and I will try to get to you in queue. I already have a few questions lined up in the queue, but I will get to you one by one. So next I have Dr. Zishan Ahmed Chatta, and he has a question. So let me give mic to Dr. Zishan, and please introduce yourself and go ahead and ask your question. Dr. Zishan, see if you can unmute yourself. I'm trying from my side, but it's not working.
Assalamu alaikum.
Ji, please.
Dr. Zishan here from anesthesia. I'm a resident of anesthesia at Refined National University. My question was, in your experience, how long is generally mechanical ventilation needed for a patient, and what are the preferred choices of sedation for drugs for sedation and neuromuscular blockage?
Oh, okay. Question for me or for Fawad? Okay, I mean, we use propofol for sedation most of the time, and we use Presidex also. That's a metaclopramide for that. As for the how long it takes, depends on the patient's outcome. But generally, in maybe within a week, either patient goes to improves or patient dies. So it's not like the patient or stay the same condition for a very long time.
Fawad, do you have any comment?
Sorry, I missed the question. So the question is, what are we using for sedation?
Yes.
That's right, and propofol
Yeah.
specific.
Those patients that we have, 75% of them, we are proning them. So we are paralyzing them with Nimbex and using either Versed fentanyl, depending on the situation, or propofol along with that. We have still enough supplies, so we don't have any problem with that. Does that answer the question? Hello? Does that answer the question? Basically paralysis and propofol in some patients, and paralysis with Nimbex and Versed fentanyl in some others. ARDS, we are not using Presidex as much just because it's hard to control them when they are prone.
Gee, Dr. Zishan, you have the mic. Do you have any follow-up question, or you think you got what you were asking?
I got it. Thank you very much.
Thank you. So next I have Dr. Maimuna Bhatt. Let me give mic to Dr. Maimuna. Please go ahead. Introduce yourself and your question.
Hi, everyone. It's Dr. Maimuna Bhatt from Calgary. I work as a family physician. So I have a question regarding the testing for COVID-19. How often we can repeat the test once it is positive. I have a patient who is being tested every 2 to 5 days, and last 4 tests for her came back positive, and she's still in the queue, like they are testing her every 24 hours. My question is how often and how long should we continue testing for her until it becomes negative, I guess?
I mean, typically we don't repeat the test again. Once patient is positive, we treat the patient, and after that, patient clinically improves. We don't repeat that unless there is some reason for that, but generally we don't repeat the test.
The reason they gave to the patient was as she works in the healthcare setting. So she works at a senior center. Even though her symptoms are not there anymore, but for the last since March 18, she did 4 tests and all of them are positive, and they are still taking swabs.
Really?
So,
that's not the typical. That's what we do. Patient if you're positive, and patient. Question is when patient can go back to work. So we tell the patient that after 72 or more, better that if a patient takes a week after all these symptoms are gone, patient fever has subsided without taking any antibiotic medication or cough or all the symptoms are gone. Even after 72 hours, they can, or even after 1 week, they can.
oh, okay.
We don't repeat the test again.
Thank you.
Very good. Next, I have a question from Dr. Muhammad Naeem. Let me give mic to Dr. Naeem. Dr. Naeem, please go ahead.
Assalamu alaikum.
Wa alaikum salam.
Dr. Avais Masud. I am from Gujranwala as working family physician. I raised my question as is HCQ is available in IV infusion form? And second is that at what level azithromycin and HCQ acts to control the infections like COVID. As COVID-19 is a virus and we are treating with antibiotics, how does it affect and for how long we should use these medicines?
So let me ask, I heard your question. First part I did not hear. Your second part is that azithromycin is antibiotics and why we're giving an antiviral to disease and how much should we give that, right? That's the question or?
Yeah, so I think the first question is that is there intravenous form of hydroxychloroquine? And second is that azithromycin is an antibiotic. How is it helping with a virus?
No, we are giving
Yes.
chloroquine PO by the tube. And the second question is that why we're giving antibiotics in viral. Actually, azithromycin has no antiviral activity, but it has some other effect on a patient who has viral infection, including that it has some anti-inflammatory and increased immune modulatory effect. So that actually has been shown in multiple studies, and that's why we give azithromycin at the same time. We have seen that in our practice also. When patient has a flu or something like this, very commonly they give Z-Pak, and they get better also. Although most of the time it's a viral infection, has nothing to do antiviral activity of azithromycin. I think that is because of that. It has some anti-inflammatory effect and also immune modulatory effect, azithromycin.
Very good. Next, I have Dr. Akhtar Munir. Let me give mic to Dr. Munir and please introduce yourself and ask your question. Go ahead.
Assalamualaikum.
Walaikum salam.
My name is Dr. Akhtar Munir from KP, Pakistan. My question was, what are the SOPs of disinfection of the area with COVID patients admitted?
Sorry, repeat the question again, please.
So if a patient of COVID is admitted in an area and later found out the patient had COVID, how do you disinfect that area? What are the standard procedures for disinfecting the area?
I mean, there's no, I mean, it's a common sense. I mean, I don't know whether I have any particular protocol to disinfect the area. I mean, basically whatever disinfecting well you have. I'm not expert in that you just have to disinfect. There is no particular protocol that this disinfectant need to be used.
I can comment, Avais, if it's okay there.
Please.
So basically, the protocol that we have is not about with what are the things we're gonna use. It's basically the number of hours. So 3 hours, the room is clean in a regular way with the PPE, and then that room is not usable for 3 hours because of the risk of those aerosolization for 3 hours at least. And that basically rule is made for OR under negative pressure rooms. However, there is a
Sorry, Fawad, you got muted in there. Can you
oh really?
what
Okay.
you were saying? Yeah,
Okay.
the 3 hour rule you were saying?
Yeah, so the 3 hour rule was made in our ORs for procedural components. If somebody is suspected or later on we find out that that there was a suspect, it's not going to be used for 3 hours and will be clean in a standard way, the way they do it using PPEs. And the same rule will apply in other areas if there is a patient that was found out later. It came back positive after a while. Maybe people didn't know and he turned out positive. So 3 hour rule is basically because the aerosolization can last the virus can stay alive for 3 hours. That's what we have in place.
Very good. So I think as far as I can tell, I have run out of all the questions that were posed to me. I think we still have a little bit of time. Unless you have any more comments, Dr. Avais, what I was thinking, we can go around with the panelists and have them introduce themselves. And if they have any comments, and then we'll go around with the attendees and have them introduce themselves and make any comments if they have any. So let me start with Dr. Rizwan Khalid. I see his raised hand. Ji Rizwan bhai?
Right. Yeah, Danish, I was going to give my opinion on the previous question that was asked about how do you clean the room and stuff. So
Ji, please.
if it's okay with you,
Yes.
in what we have is a protocol for our cath lab. So the cath lab protocol is our cath lab is a positive pressure room. So we could not change it to a negative. So we made it into a neutral pressure room. So number one. Number two, all the cupboards and we have these movable cupboards which has all the supplies. In a patient that is suspected COVID or confirmed COVID, everything has to be, before the patient comes in, has to be taken out. So that if there is any aerosol or anything, so there is none of the viruses are found on the surfaces. So everything is already out of that room. So one of our cath lab is designated for COVID-19 patients. Once the patient is done, everybody, we go in, we have to be in PPE before we go into the room. Everybody has to be with PPE. Even the janitors who come afterwards have to be wearing PPE. And then the term that we use here is terminally ill. So that is what we do. It's the same term that is used in the ORs. It is the same term that is used once you're doing devices like ICDs and pacemakers. So it has to be terminally cleaned, which means all the trash cans are emptied, all the sharps are emptied, everything is wiped, cleaned before the next patient comes in. Usually that takes at least a couple of hours. So therefore, that gives enough time. However, if there is a patient that is on a vent or is you have to do suctioning at the same time, then the concern about the virus being in aerosol is actually more, and you have to wait at least 3 hours, because that is what it is said, that in aerosol it can last at least three hours or so. So that is the protocol for our cath lab that we use. Now that may be different for a actual ICU room, but I just thought it may be interesting to share how our cath lab does its terminal cleaning. Thank you.
Thank you, Rizwan bhai. I see that Dr. Maimuna Bhatt has a question. Dr. Maimuna, please go ahead.
Hello.
Ji.
Hi. About the immunity against COVID, I know it is quite premature at this point. We don't know if once the patient gets COVID-19, would he be protected for a life against it? Would he be acquiring the immunity? Or is it like, or maybe at least for a year, and next year, if it comes back again, it would be like that, like a flu shot we do every year? Would it be something like that? Or I think it's quite premature right now to say that, if anybody knows.
Okay, let me start with my comments. Masud. What so far, obviously nobody can say anything definitely, but luckily we found that the mutation, this virus mutates very slowly compared to influenza virus. So that's the hope that once you have the immunity, it will last longer rather than just for like one season only. So now, initially, most people were saying that, okay, every year we have to have vaccine, but now more people whom I know, they have expertise on this subject. They think that the immunity will be much longer, many years, or could be many years, once the patient has recovered from this infection.
Dr. Fawad, please go ahead.
Yeah, no, I just had the same follow-up thing as Dr. Rizwan was mentioning. The same way we have just wanted to throw a little bit light on the how the procedural components and other things intervention-wise we have been doing. We also have 5 ORs dedicated, as well as even all the the interventional bronchs are done there. and the same rule as Dr. Rizwan was mentioning, the all PPEs and all that. And we have made some extra negative pressure rooms in the OR as well as in the ICUs. Also, to the follow-up to the same question, all the COVID suspects as well as COVID positive, there are floors dedicated to them, which I think it's common sense and most people are doing it, but just wanted to throw out there. So that's pretty much it. That was a comment.
Very good. I think we have still some time. So what I want to do, what I would really love to do, is to go around and have the attendees introduce themselves one by one. I have Dr. Abdul Hafiz here. Dr. Abdul Hafiz, would you like to introduce yourself and have any comments or questions? Please go ahead and unmute yourself. Okay. I have Dr. Muhammad Naeem raised his hand, so I'm going to give you the mic over to you. Dr. Muhammad Naeem, please go ahead.
Doctor, we are in Pakistan and we see everything is new. This is a newborn baby in Pakistan. We don't know previously any COVID-19 virus in Pakistan. But you have dealt with so many cases in Europe and in Pakistan. How we should keep them in general practice, dealing with the patients in a small chambers? Should we?
I mean, that's a tough one. I mean, really, I have a friend who had the same question from me, asked my opinion. He showed me a picture of his clinic and how unprotected he was with just like a surgical mask wearing, and the patient coming to him with a coughing and fever. I was very worried about him, and I told him that, I mean, not just me, because on Facebook, many of his other friends also asked him to, close his clinic for a few days and disinfect everything. And after that, I mean, I don't know, you have to be creative over there, like how to protect yourself from those patients. I mean, obviously, you have your own resources. I don't know what, but can't suggest anything specific. But again, it's a very dangerous situation. That's most worrisome. You should have at least, I don't know how you would get this while seeing this patient. Isolate yourself by some, some glass or something, and if you could get some N95, I mean, it's not easy. You should get that. So it depends on what resources you have. I mean, you have to be taken very, very seriously. This matter is very difficult.
I see Dr. Mariam is sharing a screen, so let me get the mic over to her and see if she want to make any comments on what she's showing. Dr. Moteen?
Yeah, I was just trying to show you the protocol that has been laid down by our hospital, the Loma Linda University Hospital. And I thought it would be worthwhile if you want to just look at it and see if that's the protocol that you want to put up for Pakistan. Basically, anybody that's come in with respiratory failure, which is suspected and or confirmed for COVID-19 patient, we look at the hypoxic level, and initially, always, as ever, you start with the nasal cannula and then go into high flow nasal cannula up, and then consider about putting patient into endotracheal intubation. Generally, it is very important to have every patient, everybody that's in the room, to have PPE before intubation, just like in any other place that you would like to. But the important thing is to make sure they have their blue gowns on and everything before they are taken in. So that was one thing that I thought it was worthwhile just to look it over.
Yeah, bahut shukriya. So I have Dr. Abdul Naeem from Pakistan. Let me see if I can give mic to Dr. Abdul Naeem to introduce himself and see if he has any comment. See if you can unmute yourself, Dr. Abdul Naeem. Please go ahead.
Assalamu alaikum. I am Dr. Naeem from Islamabad, practicing physician. I have sent you one question also, but how to disinfect like primary care practicing physician in Pakistan. They have small clinics, 1 to 2 rooms, and there is a chunk of patients. They come around, and it is too difficult to control the traffic. And what basic steps they should take over so that we can send the message like you can manage the things like this. Thank you.
जी अवैस भाई.
I think we were talking about the same thing just a minute ago. Again, that's a very risky situation, very dangerous situation when you have limited resources. How to protect yourself? Again, least you can do that. I don't know, you can afford to have that or not. Like at least give a patient like a surgical mask if you can, and obviously you should have a mask. If not N95, you should have a surgical mask. And also, if you could isolate yourself by some glass, from the patient, you have to be creative. I have no idea that what are your resources are and how you can protect yourself, but this is a very worrisome situation, and you folks are facing that. Again, I told you that one of my friends told me in Pakistan that he sees patients who are coughing and fever they have, and they come into clinic. What should they do? I have no particular suggestion. Just do your resources, and mask is the thing least you can do. Give one to patient if you can afford to have that, and obviously you have to wear yourself also. So just have to be creative.
जी बिल्कुल. Dr. Kabani, you have some comments or question? Please go ahead. Introduce yourself and your comments.
Yes, this is Dr. Noor Meher Kabani from Houston. I'm a tele-intensivist, and the questions that are being addressed right now about disinfecting small clinics and how do the private practitioners deal with this situation made me think about what is happening over here. I'm a tele-intensivist, so I deal with telemedicine a lot. If at any point in time it is important to do telemedicine, even in the smaller clinics, this is the time to do it. I was very pleasantly surprised a few minutes ago. I saw on my Fatma Jinnah WhatsApp forum that Fatma Jinnah Medical School has started a telemedicine center already. And this is just something that I'm putting out there to think about, because the means of communication are there, technology is available. Look at us all together. This would be the time. Now, of course, at the receiving end, the patients may or may not be able to do that. But if you could even do, to some extent, some tele visits and teleconsults with patients, that would be, even over an iPhone or even over a cell phone, I think that would uh, alleviate some of the issues of patients coming into the clinics.
Thank you so much. So Dr. Abdul Hafiz, please go ahead and unmute yourself.
Ji, Assalamu alaikum. This is Dr. Abdul Hafiz. I'm a family physician in Manchester, UK. I think the previous two questions which were asked, maybe I just wanted to, share some of the experience from UK on that particular side.
Ji, please.
My first point is regarding the patients who are coming to our clinics here. We are actually screening them right at reception before they actually walk into a clinic itself. Majority of times, the patients who actually have any flu symptom, we are not allowing them to enter our clinics. Rather, we'll ask them to go home and ring us. We mentioned telemedicine briefly there as well. So most of the times we are able to get history and then make a quick assessment in terms of what needs doing. The guidelines in UK is that we shouldn't, examine the throat of these patients because we are putting ourselves at risk in that situation, which means we are issuing much more antibiotics than what we will normally do in normal circumstances. The second point is regarding decontamination in our rooms. When a patient like this come, so when you suspect, obviously there are flu symptoms, though it may not be COVID, we actually clean everything after patient is gone, with antiseptic wipes, door handles, the chair, whatever we might think the patient have touched, as well as our equipment. My third point is regarding these patients who are not coming with actually cough and cold symptoms, because the experience from UK shows a lot of patients who actually are carriers. They may be, they might have cotton infection, but they are still in an initial phase. They may still be spreading infection even before actually having full-fledged symptoms. So we assume that every patient which walks in is a suspected COVID rather than having actual symptoms. So we are trying to be more careful in terms of, every patient we follow the same protocol here. Thank you.
Thank you so much, Dr. Hafiz. I have Dr. Muhammad Azim Imran next. Please go ahead. Dr. Azim Imran. So I can read the question. Dr. Azim Imran is from Faisalabad, and he was asking if someone can elaborate on COVID-19 and infections in children. How much risk is there? Is the course of the disease any different?
I mean, we luckily don't have, I personally have no experience, and I don't see children, but been listening reports that very few children are affected, but they are. They are not totally immune from this infection. Actually, the youngest child who died is an infant just a few days ago, I think from Chicago. So that's just one case so far. So again, there is very little experience about dealing with the children, but I don't think that the treatment or precaution would be anything different. Mainly, most likely, all those children, if they get the infection, will be treated with the symptomatic treatment only. And hopefully, they will get better from that because.
Fawad, please go ahead. You wanted to add something?
Yes. So about children, I have nothing further comment. As Avais said, it's exactly the same. But I have a slightly different comment regarding vertical transmission from pregnant females to the newborn. So we've reviewed the data. In infants in China, there is a 38 female study that showed no vertical transmission from all positive females for some reason. Having said that, in OU Medical Center children component, we already have one vertical transmission. So bottom line is, this is so new and everything is changing every day. So far we believe there is a vertical transmission, but in my own center there is one. So, the same way, we know that children have been involved much less, probably because the coronavirus family has been, the children have been exposed in general to coronavirus family, so they're more resistant to it. But that is not a rule. So unfortunately, we can see it in kids as well. We haven't seen, that's lucky, but this virus has been doing a lot of different things, and every day we are learning new things.
Dr. Hafiz, you have a comment? Please go ahead.
In terms of children, our information which we have from UK is, I think probably a global picture as well, that it's actually not affecting children as much as the elder age groups. However, there has been situations within UK. I think even yesterday we had a death of a very old, very young baby, like 6-month-old. We had a 13-year-old patient, a young child with no underlying medical condition who actually passed away. The classical disease pattern is that for the first 5-6 days, the child might have just very basic cough and flu type symptoms, and it's usually day 7 to 10 that's the time when the shortness of breath actually start in these patients who become really sick. So that's the observation which we have, but I don't think it actually changes anything in terms of what we do. The treatment is exactly same what everybody else is doing.
बहुत शुक्रिया. Dr. Farah Nawaz, if you can kindly unmute yourself, introduce yourself, and see if you have any comments. Dr. Farah, please unmute yourself. Okay, I have Dr. Fakhra Jabeen. Please go ahead and unmute yourself and introduce yourself and see if you have any comments. Okay, I have Dr. Nurul Nisa Pasha. Please go ahead and unmute yourself and see if you have any comments and introduce yourself. And I have Dr. Tosif Irfan. If you want to unmute yourself and introduce yourself.
Hello, can you hear me?
Yes, please go ahead.
Okay, I'm Dr. Tosif Irfan. I'm a family physician with a special interest in rheumatology, and I've been working with a consultant rheumatologist, Dr. Nigat Mir, for the last 10 years or so. So presently, what we are concerned is that all patients are naturally housebound, but they're all on immunosuppressants, and hydroxychloroquine is absolutely finished from the market. It is a local problem, but all the people, they have, I don't know, hoarded or what, but HCQ is finished. And our patients, like SLE patients, systemic lupus erythematosus, or rheumatoid arthritis, they are all badly in need, and the medicine is in short supply. And the second thing is that naturally in these days of COVID-19 infection, the immunosuppression is an added risk factor for all of our patients. Most of our patients are thus high risk because mostly they are on 1 or 2 DMARDs. I really don't have a question because I'm more interested at the moment in learning and listening. Thank you so much. Thanks.
Bahut shukriya. Thank you so much for being here. Dr. Farah Nawaz, you're next. Please go ahead.
Assalamualaikum. My name is Dr. Farah Nawaz. I want to ask about basic question about personal protective equipments. There is a lot of question about mask, different types of mask wearing. Is there any difference between these qualities of mask regarding protection of viruses? I mean, there are some news that these viruses have a certain size which needs to be filtered through some pores.
Ji, Dr. Avais or Dr. Fawad, do you have any comments?
I mean, basically, there are different type of masks. Mainly, there are 2 types. One is like a typical surgical mask, and another are, we call it N95. So basically, surgical masks have some protection, but it's basically not a big protection that are generally are okay if even patient with COVID positive, the patient is not receiving any aerosol treatment, the patient is not coughing or sneezing, then it's okay. And if you are wearing mask and patient is wearing mask, as per the CDC recommendation, as you are okay, that you don't need to do more than that. The other mask is N95. Actually, N95, you cannot just have N95 and just wear that. You have to have N95 size, which you have to have a fit test prior to that. What size you fit into, like small and medium, what size you fit to you, and you should wear only that. Otherwise, it will give you less protection. If you have fit test and you have proper N95, it gives you pretty good protection. Even when you're doing some procedure or you are exposed to a patient who has procedure or solar treatment. So that is, but again, nose and mouth is not the only area of the mouth or body which need to be protected. Once you're facing patient, I mean, all body should be covered, even your glasses, fit-tight glasses, everything need to be protected. But in generally, unless you have a fit test done, N95 are less protective.
So so I can just add to a little bit. I think the particle size of COVID particles is 0.25 to 1 micron. And usually N95 masks have been used for TB, and TB is up to 5 microns. So that is from preliminary data. I don't know where exactly I reviewed, but this is on one of the CDCs or somewhere. But the particle size is slightly smaller than even TB. So again, I think CDC has been changing, as Avais said, the recommendations are surgical masks. But in most centers, the recommendation is if you have N95, use it for positive and suspects, both N95. Fit test is very important. Another thing that I want to add to previous discussion, fit test cannot be done with a beard. So that's another thing. I myself have it. If you have the beard, then you cannot do that. Then you have to have a pepper, which is an extra level of protection. That's a whole, your whole face and mouth is covered with the negative pressure. So those are very expensive. They may not be as readily available in Pakistan. But at the very least, I think N95 should be done and post fit test, because again, if that is not done, that defeats the purpose. Secondly, N95 can be used as long as 3 to 6 months. Again, talking about TB, in this virus, what we are doing, if it gets damp or it gets wet, then it's useless. So in our center, policy is for 1 week use of N95, but we protect it by putting a surgical mask in front of it. Each encounter, we come out and throw the surgical mask and then put the N95 in our pocket. And then you can also sterilize with, the baby sterilizers and all that. You can sterilize your mask as well. So these are my comments on that.
Thank you, Fawad. So I see a few people have comments, and I'm going to try to go to them as quick as I can. But let me start with Dr. Nurun Nisa Pasha. Dr. Pasha, please go ahead. Okay. I will go to Dr. Kaleem Ahmed next. Dr. Kaleem, please go ahead. Introduce yourself and your comments.
My name is Kaleem Ahmed. I'm a pulmonary critical care and sleep specialist here in Maryland. I'm going to be talking probably on this coming Saturday. We'll go over step by step and everything else, but there are a few comments on the discussion. Want to my 2 cents. Number one, there's a good, interesting discussion, and I think there are a couple of questions came from Pakistan about infection prevention or other thing. Yesterday also, somebody mentioned that there was no negative pressure room in even the big hospital, like in this hospital, where, and then also there's only few negative pressure room in AKU, JPMC in Karachi, and Civil also had the same thing. So we can talk about all this thing which we are doing here, but if our intent is, then we need to see how we could gear ourselves in terms of providing our fellow physician in Pakistan what they can do in their environment. I think one suggestion came that look into their local resources. There are a couple of things which I want to mention. There is a position paper from the National Ventilation from WHO for infectious disease. Mostly in third world country, like in Pakistan, TB was a very common and still common. And the people who have experience in infection control in Pakistan, I think they are much more aware of their surrounding. And I think if we can get hold of them and their ideas and their recommendation in terms of open ventilation and natural ventilation and all 3 different types of ventilation, which is done in third world country, we can incorporate it in their institution as well. So that's one thing. Second is there is I think there's a lot of discussion about medication and anecdotal thing. I think we have to continue what we have right now, as Avais and Fawad has mentioned, and other speakers yesterday, Sajid was talking about. So doing all these things is important, And then we just have to see what else we can do in terms of guideline, providing the step-by-step approach. That's about it. Thank you.
Danish has muted himself.
All right, thank you so much. So I think we can try to close here. I'm out of all the questions, and I'm gonna give the microphone to Dr. Shahid to see if he has any closing comments. Shahid bhai, please go ahead.
Okay, can you hear me?
Yes.
Okay, thank you everybody. Again, a very interesting second day. I think we are making progress. More and more people from Pakistan are joining. And I think we are learning as we go, like Rizwan Khalid has mentioned yesterday that we should introduce ourselves. We just didn't want to spend too much time on introduction, but maybe in the beginning, if tomorrow there are few people, we can start with the introduction so that the people who join will not miss valuable information by the speaker. But this introducing ourselves on the chat is also good, so that we know who are the participants and attendees, and as well as panelists. I think we are all learning as much as we are providing information to others. So it's a really good group. I feel very good that this is a resource at this point. Pakistan, fortunately, has not seen as